Okay, I think we have to go on because time is running. And we go to Ehud Raanani from Sheba Medical Center, Septal Myectomy, Global and Israeli Experience. Please.
I wish good luck to Udi.
Dr. Keren, dear guests, I'm a last-minute substitute for a French surgeon who was supposed to come, and I hope to replace him well. And in the next 10 minutes, will try to convince you that surgical myectomy is still the best treatment for symptomatic obstructive cardiomyopathy, for most patients at least. So we talk a lot about the Mayo Clinic, and they really perform a lot of cases. These are the total results in their series, with a very low operative mortality of 0.8%, a significant and almost complete reduction of LVOT obstruction from 67 millimeter mercury at rest to 3 millimeter after surgery, and 94% of the patients are in New York Heart 1 or 2. And this is maybe the reason that the numbers of septal myectomy performed in the Mayo Clinic are rising exponentially in the last 10, 20 years. And they do between 150 to 200 cases a year now. I have to present also our small experience, which we presented yesterday, the full study, but just a few slides. We have experience of 77 patients that we performed since the end of 2004. All patients had, the mean rest gradient was 56, and after provocation was 80 millimeters. The mean age was 61. There were 47 males and females. It's interesting to see that most of the patients, about 60% of the patients, needed concomitant procedure, like aortic valve replacement in some of the cases, coronary bypass, Mays procedure, aorta replacement, and more importantly, 20% of the cases needed procedure on the mitral valve, either mitral valve replacement, either mitral valve repair, due to organic disease of the mitral valve. Preoperatively, about 50% of the patients had a significant mitral regurgitation, and as I told you, about 20% of them, it was organic. The rest were SEM-related mitral regurgitation. And there was a very nice correlation between the LVOT gradient and the severity of MR preoperatively. So during surgery, as Dr. Keren showed, we do the regular trans-aortic septal myectomy. Before the operation, in the intraoperative echo, we measure exactly the length of the muscle that we want to reach in order to cut the muscle all the way down to the mitral septal contact. And in the end of the operation, we can compare the piece of muscle that we took out, that it correlates with the measurements of the echo. During surgery, this is a small, clip. The operation is relatively a simple operation on cross-clamp transverse aortotomy, exposing moving the aortic valve away, exposing the septum, and cutting the piece of muscle in the size that we measured during the preoperative echo. It's a very short operation and safe, as you'll see in a minute. So the early result, there was no operative or early mortality. There were no strokes. It's a mistake here. The pacemaker implantation rate was not 10%. There were 8 pacemakers, but 3 of them were implanted preoperatively in those patients, and 5 were new pacemakers. The length of stay, the mean length of stay is 7 days, and the postoperative echo showed a significant reduction to 1-digit numbers of the LVOT gradients in most patients, and reduction in the MR, and only 2 patients left with the moderate MR. So what is the difference between ablation and myectomy? You see these pathologic specimens, and you see on the left-hand side the scar created by the ablation compared to the normal muscle after myectomy with the hole where the myectomy was performed. This is a very nice MR study that was published in 2007, showing the amount of tissue that was injured during the procedures. On the left side, you see that after septal myectomy, the mean percentage of LV mass that was taken out was about 2.7% of the LV mass, in comparison with the septal ablation on the right-hand side, which was 8% of the LV mass scarred, and it ranged up to almost 14% of the LV mass. Dr. Keren showed the meta-analysis. This is the most comprehensive one that was published in 2010. It includes also the paper that Dr. Keren mentioned from Toronto. And the first slide shows a very promising, the short-term mortality is good in both procedures, very low short-term and procedural mortality. But when comparing the post-intervention pacemaker implantation, most of the studies showed significant number of post-intervention implantation in the alcohol septal ablation, and that favors significantly the septal myectomy. Post-procedure New York Heart class was better, in most studies, was better with the septal myectomy significantly. And probably the most important finding is the post-procedure left ventricular outflow gradient, which was significantly lower in the septal myectomy group. And this is the most important finding because there are a lot of studies that shows the importance of the residual LVOT gradient. And this is from the cardiology group in the Mayo Clinic that showed the correlation between residual LVOT gradient after septal ablation and survival-free mortality. And you see that a difference in 10 millimeters of gradient, those who had a residual gradient of more than 10 millimeter in the LVOT had significantly reduced survival compared to those who had less than 10 millimeters. So even a small LVOT gradient left after septal ablation was correlated with reduced survival. And they looked at the predictors of all-cause mortality, and you can see that also in the predictors of all-cause mortality in a multivariant analysis, post-ablation LVOT gradient higher was correlated in a multivariant analysis as a predictor for mortality. And when they compare the myectomy patients to the ablation patients with the survival-free death or need to additional septal reduction therapy, Dr. Keren showed the overall, without the additional septal reduction therapy, there was a significant difference in those outcomes between myectomy patients and those who underwent septal ablation. Regarding the hemodynamics, what are the predictors for hemodynamic success in alcohol septal ablation? And you can see that there are several predictors that showed that if you have those predictors, they are favorable for septal ablation with a good hemodynamic success. And the variables are age more than 65, LVOT gradient less than 100 millimeters of mercury, LAD, which is smaller than 4 millimeters, basal septum smaller than 18 millimeters, and you have to have an experience of more than 50 patients in order to get good hemodynamic results. And only if you have 3 or 4 of those favorable variables, you can get a survival-free of severe symptoms, which means class 3 or 4, Canadian class or New York Heart class, of 80% in 4 years. So you have to have a very good anatomy and a very good experience in alcohol septal ablation in order to produce good symptomatic relief. And as Dr. Keren said before, probably the most important indication for intervention in those patients is symptoms. So this slide, I think, shows it all. I would just mention this paper from Rotterdam, from the Netherlands, a word of caution, the group from Patrick Series, who showed the long-term survival comparing between myectomy and alcohol septal ablation, which shows significant difference between the groups. And I will conclude by saying that both procedures provide low early mortality. There's more reliable relief of gradient with septal myectomy, less collateral myocardial injury, fewer AV conduction problem, which is probably very important for younger patients, and maybe less arrhythmias in the myocardial septal myectomy. Fewer anatomic limitation I did not discuss, but surgery can also treat mid-ventricular or even apical hypertrophy, and of course the alcohol septal ablation cannot. And of course, during surgery, as I showed you in our series, we had 60% of patients who needed other associated procedure during the surgery. I think there is a place for alcohol septal ablation in high-risk elderly patients who have symptomatic cardiomyopathy, obstructive cardiomyopathy, but I think in most of other patients, septal myectomy is still the best solution. Thank you.
Thank you very much. Thank you. Gad, I think you have a question?
Can you put up your conclusion slide, please, Udi, if you can? Can we have back the last slide, please? First of all, thank you for a very nice presentation, and I would like only to answer a little bit a few ideas you came up and showed us. First of all, I would like to say that, only the conclusion, that collateral damage which you showed in the Valetti paper, which we have just seen, 8%, is actually after performing the MRI between 5 and 8 days after the procedure, not during long-term follow-up. So there is a shrinkage of this area, and we all know that today. The second point I would like to make comparing the two procedures is that there is no doubt about the better and more controlled decrease in the gradient. The point is that in the same paper you showed us, there was no difference in the symptomatology of the patients thereafter, and no in long-term survival, and no difference in the same Mayo Clinic paper, no difference in the incidence of sudden or total death. Therefore, at least at that point, I really do not believe that we should say that we have a clear picture of what's going on, even if it's clearly you have a better result in all series of abolition of the gradient. And you said that one of the most important issues is the patient symptomat. Can we have the last slide, the conclusion slide? You cannot move. Okay. So you said only one word. You said that it's the most important. It's a very important issue, the symptomatology. I really believe it's the only issue in sending our patients to these procedures. That these procedures are not free of danger, and I also do not believe that at that point, after 10 years follow-up, we can say that only very old and incapacitated patients should go for alcohol septal ablation. This probably will not be accepted by most interventionists today in the world, even if they are very critical of what they do, exactly the way we do PCI and coronary bypass, and we have more interventions after PCI than after coronary bypass. Is the same situation here. We have no proof whatsoever that performing alcohol septal ablation, not in very young, but in the population I discussed previously, cannot be very helpful, and probably as helpful today we know as myectomy.
The reason I just want to answer regarding the symptoms, and I think that if you pick the right patient in alcohol septal ablation, and it's a really selective group, then you can have good symptomatic relief. But again, as this paper shows very nicely, you have to have very good anatomical situation and a very good experience. And if you have all those together, then you can have a survival free of symptoms of 80–90% at 4 years.
This is absolutely true for both procedures. They need really expertise, and expertise should be concentrated, particularly in such a small country as Israel.
You see, it's not easy. You probably need a hypertrophic cardiomyopathy team I think, in each center. There is one here. Okay.
Yes. When you compare the studies that compared the two procedures, they look directly and strictly at the results on very strict criteria. But, as you said, 60% of the patients do need something else in addition to help them live better. In addition to that, everybody says the mortality and so on is the same, so why not have a better result with myomectomy? And 20% with pacemakers and infection drug associated with pacemaker or whatever is not acceptable in my opinion. So it's an interesting procedure. I don't buy it personally. I sent 15 patients to myomectomies, 10 had it, 5 didn't. I'm happy with it. Everybody lived, they're happy, zero gradient, they run on treadmill. I'm afraid of this procedure, frankly to tell you, because of the scar, because we don't know, because some of them have mitral valve repair and so on, and so many other things. This is my personal impression. Regardless of whatever they will tell you in papers. Thank you.
It is, I believe, impossible almost to convince the convinced, so I just can show you all the data which show exactly the opposite of what you say, but because you are so convinced, I suppose that you should remain convinced.
Okay. Well, the only problem is we do not have any prospective, true comparative study. That's the only problem. We'll probably never had it. So, if you are a surgeon, you believe in surgery. If you have a CAS guy, you believe in CAS. If you have a clinician guy, you have to make the choice yourself.
I also would say that the numbers cited here of the associated lesions and which bring us to send the patients to additional procedures because of additional procedures is about less than a third of the patients, probably less than 1/4 and not 2/3.
Okay, I think we have to move. Thank you very much. We move to